Today I'm presenting my 8-week Phase 2 cardiac rehabilitation program for Charlie, a 59-year-old woman who suffered a STEMI following total proximal right coronary artery occlusion, successfully revascularized with a PTCA. And so I'll cover my clinical interpretation, evidence base, deviations from evidence, and behavior change approach. So client profile: Charlie STEMI caused an ischemic damage to the inferior myocardium, impairing cardiac output efficiency and oxygen delivery to working muscles. So this explains her VO2, a peak of 28 milliliters per kilogram per minute, below age expected norms. So her left ventricular ejection fraction is 55%. Exercise ECG is unremarkable, which is all cleared by Braiger 2025. The most critical prescription factor is metoprolol, a beta blockade that blunts the sinoatrial node response to sympathetic stimulation, making heart rate an unreliable intensity guide. Consistent with Mazzani 2013, RPE is a primary throughout all the 8 weeks, and heart rate is secondary only. Psychosocially, she is recently retired. She lives alone and she walks her dog Branson, which is already established. So that routine it becomes a central behavioral anchor. So for short-term goals, we are looking at specific measurable targets. So goal 1, cardiorespiratory fitness. VO2 peak is at least increasing by 10%. So VO2 peak is the strongest independent predictor of cardiovascular mortality in post-MI populations, making it the most clinically significant outcome for this program. Anderson 2016 demonstrated 11 to 18% gains from exercise-based cardiac rehab, supported by Taylor 2004. So for goal 2, blood pressure reduction. In systolic blood pressure, we want to reduce it by at least 55 milligrams of mercury through aerobic training, which reduces sympathetic activity and peripheral vascular resistance. Cornelison and Smart 2013 confirmed 5 to 8 millimeters of mercury reductions, complementing metoprolol's antihypertensive effect. So with goal 3, we are looking at body composition, where her waist is at 94 centimeters, which elevate metabolic risk, and we want to work towards going less than 88 centimeters. And so with goal 4, we want to work towards 150 minutes per week of moderate physical activity by Wood-Ruffle 2015 by the Australian ACRA guidelines, which is cited over AHA for clinical consistency. So for goal 5, muscular strength, we want to look at 30-second sit-to-stands with an improvement over at least 3 repetitions from baseline, which is directly relevant to Charlie's 2-story home. So with an 8-week program structure, we want to look at the 4 phases. So weeks 1 to 4, we are looking at 3 supervised sessions, no home resistance. Charlie needs to work towards supervised RPE calibrations and techniques feedbacks before she goes into an independent exercise. So by week 5, we want to start to implement supervised sessions where we're reducing the sessions to 2 and having a 1 home scheduled body-weighted circuit, which is introduced at the same time. So by this point, Charlie should have completed 12 supervised sessions by week 5, and with Williams' 2007 study, it says that it supports home resistance in stable MI patients with adequate supervised training. So by then, Charlie should have 12 sessions meeting that threshold. So by weeks 7 to 8, we want to consolidate to the full program, where RPE again is the primary indicator throughout the entire exercise program. So aerobic prescription, we are looking at in week 1, we are deviated from the continuous aerobic format recommended by Anderson 2016, prescribing an interval format instead. In early post-STEMI populations, the myocardium hasn't fully recovered from the ischemic injury, so continuous exercises carries higher hemodynamic instability risks. Therefore, 2 10-minute interval bouts with 5 minutes of active rest below allows blood pressure and heart rate monitoring between bouts. So the active rest is a clinical safety checkpoint. By week 8, we transition to 12 minutes of steady state of 3 2-minute intervals at RPE 13. And so Rogmo 2012 shows prospective multi-center study, nearly 5,000 patients with demonstrated interval training and had a low adverse event rate in stable coronary heart disease. Pipoli 2010 established structured aerobic exercise as the cornerstone of post-MI rehabilitation. Key deviations both weeks. Metropolo makes heart rate unreliable, as stated by Mezzani 2013, supports RPE guided intensity under beta blockade. RPE, again, is a primary exercise for intensity. So for resistance training, Williams 2007 recommends 2 to 3 resistance sessions per week post-MI. By week 8, Charlie achieves this with 2 supervised, 1 independent session and 1 home session. So in week 1, resistance training starts with body weighted exercise with 1 set and an RPE of 10 to 11 with wall push-ups over floor push-ups to minimize intrathoracic pressure. So this is relevant in early post-STEMI POPs where elevated pressure impairs cardiac output. So with the dead bug, we are also providing low demand on core activation with no axial spinal load. So while sitter stands and step out taps are functional for Charlie's 2-story home, we also want to restrict Valsalva throughout all of the exercises. So by week 8, Charlie progresses to 2 sets at an RPE of 12 to 13, with goblet squats being chosen over barbell squats to reduce the spinal compression. And for Pallof press, we want to progress from dead bugs into a standing anti-rotational exercise. The key safety consideration is that the loaded exercises remain supervised only, and that at home Charlie uses bodyweight exercises only, keeping intensity at a cap of RPE 12, keeping her mobile phone nearby since she does live alone. So safety and monitoring, we want to embed these all throughout the 8 weeks. So pre-session and stop criteria follows the Fletcher 2013 study. So no commencement of activity if her systolic blood pressure is above 180 and her diastolic blood pressure is above 110. So we also don't want to do it if her resting heart rate is outside of the 50 to 100 beats per minute spectrum, and we don't want to undertake exercise if she is experiencing new symptoms or hasn't taken her medications yet. So 2 specific modifications would firstly be metoprolol. So heart rate reserves targets 107 to 131 beats per minute, which is documented. However, we want to use it with caution only. So secondly, post-exercise hypotension. So post-MI patients have impaired autonomic regulations of peripheral vascular resistance. So abrupt cessation causes venous pooling and blood pressure drops. Mandatory gradual cooling down sessions every session. So week 8 cool down runs for 6 minutes. So because post-interval hypotension risk is elevated. Again, she should have a mobile phone on hand when she is at home. So behavioral change theories, which is embedded across all of the 8 weeks as well. So 6 are cited from Michi 2011 studies selected for Charlie specifically. So BCT 1.1 would be at goal setting. The key point here is that the goals are agreed collaboratively with Charlie, not prescribed. This helps build self-efficacy, which links to Bandura's social cognitive theory. And so BCT 1.4 is action planning. For example, when Charlie wants to go for walks with Branson, she also completes her 30-minute walk. This uses Gollwitz's if-then planning approach, which then links to behavior to an established existing routine. Instead of creating a completely new habit, programs build on what Charlie already has. And thirdly, self-monitoring, 2.3 BCT. Charlie uses an exercise diary from week 1, which is reviewed every session. This provides accountability and allows progress to be tracked over time. And so with BCT 3.2 social support, we are looking at from week 5, group walking is introduced, which is leveraging Charlie's extroverted personality and existing friendship network. Moving on to graduated autonomy, supervised sessions are reduced at week 5. While a home circuit is introduced, we are looking at introducing it at the same time. So this supports self-determination theory by building on what Charlie's competence and independence before she is discharged to phase 3 of her rehab. Finally, relapse prevention is a contingency plan that is embedded proactively each session. So home exercise prescriptions. So home exercise is introduced deliberately to build Charlie's independence for phase 3 rehab. So weeks 1 to 4, we can see that she only has walking only, no home resistance training, as Charlie builds supervised exposure first. So her walks do progress from 2 times for 20 minutes to 3 times for 30 minutes a week. So week 5 introduces a home body weighted circuit as a home as a scheduled session, not a contingency. So this replaces the lost supervised session operating on graduated autonomy. So starting at 3 to 4 exercises with one set at an RPE of 11. Then going on to week 6 to 8, it is to progress Charlie towards a home circuit. This builds with 6 exercises with 2 sets at an RPE of 12. So by week 8, Charlie will have completed 5 walks per week, which reaches 150 minutes of aerobic activity plus 1 independent resistance training session at home. This supports a smoother transition. The key to safety rules are that all home programs are body weighted, so intensity stays at an RPE ceiling of 12, and Charlie is to exhale and during every repetition, and her phone again is nearby at all times. If any symptoms do occur, to please stop. So to summarize, the program is built around Charlie's key clinical considerations: ischemic myocardial injury, preserved LVEF, and hypertension, and metoprolol use. So aerobic training does start conservatively in week 1 due to early post-STEMI hemodynamic risk, then progresses to intervals at RPE 12 to 14 by week 8. Then resistance training progresses from body weighted to supervised loaded exercises in the clinic, with a home circuit introduced from week 5. By week 8, Charlie completes 3 resistance sessions per week. The program follows Australian guidelines where available, and international standards are used where the Australian equivalents are limited. So finally, 6 BCTs are embedded throughout the program. Branson acts as Charlie's behavioral anchor and helps build routine and adherence. By week 8, Charlie should reach 150 minutes per week and has greater independence and is prepared for phase 3 of her rehab. Thank you.